first of all, huge thank you to Professor Balaman and Tedo Khan for hosting me this week at TED University in Ankara, Turkey. I've had such a fantastic time through this week meeting colleagues at the Conversational Analysis Research Group. What I want to do is hopefully offer you a flavour of some of the work that I do from some broad brush topics relating to my research, and at the end of it, share some early findings of a paper that is in preparation. But in order to do that, I will have to share some findings from earlier research along the way, just to give you an understanding context of the research domain that I'm currently working in. So just to start with, as Professor Balaman said, my name is Dr. Simon Stewart. I am a lecturer in psychology at Staffordshire University, and I've been there now for 3 years, just under 3 years. Now, these are my research domains. Although I do have research interests in developmental psychology, it's health psychology, social psychology, and applied health services research, along with developmental psychology in the area of social interactions of children for the purpose of learning in the wild. So for the purpose of today's presentation, I am looking at social practices that are enacted within specific healthcare settings to see the implications of these actions. So the domains of health psychology, social psychology, and applied health services research apply here. Now, when it comes to my research, as Professor Balaman noted, most of my research is in the domain of conversation analysis of medical interactions. And what I'm going to be talking to you today about will largely be in the context of localized prostate cancer. And in particular, rather than focusing on just doctor-patient interactions, I'm going to be focusing on multi-party interactions that comprise a patient, their partner, and a clinician to better understand the back and forth of such a configuration of interaction as standing distinct from the typical dyadic and the dynamics within that type of consultation. Some of the research topics that I have carried out in this area look to understand simply how partners come to be involved during these consultations and what they do during these contributions and the import for the consultation. I have examined how clinicians orient to expressions of treatment preferences, which I'm going to be outlining in one of the published papers from my PhD. And also in preparation is a paper that is examining how the sexual impact of prostate cancer is communicated to couples during these consultations. Now, first of all, I want to offer some crucial context about prostate cancer. I'm going to talk about the prevalence, some of the contemporary debates, and also how it's treated and the import for couples of this condition. So when it comes to prostate cancer, what's most important to understand about it is that it typically affects older adults. That is to say, typically 76 years old at the time of diagnosis, but it's important to recognize that some people are diagnosed with prostate cancer under 50 years old. This is the most common cancer for people with prostates, and that amounts to, in the United Kingdom, 47,000 at the moment new cases annually. The good news for this is that it's highly survivable. But even being highly survivable leads to 11,000 deaths per year. And those who do not get killed by prostate cancer, survival can come with long-term conditions which will persist in some occasions for the rest of the patient's life. Now, when it comes to low and intermediate risk localized prostate cancer, this is a specific condition, and as the name suggests, localized means cancer is contained entirely within the prostate. And what's crucial is for most of these, it is typically slow growing and can have near to no impact on a person's quality of life or life expectancy, particularly for low-risk prostate cancer. And in this respect, most people actually die with prostate cancer and not because of it. And you may have noticed on the previous slide the Prostate Cancer UK statistic, which is 1 in 8 people will get prostate cancer. Now, a paper recently has been published outlining the current debates around the low-risk prostate cancer category, which is also described as Gleason 6, where there is a move to take away the name cancer from it and describe it as indolent lesions, with the concern being that there is an era of over-treatment for this form of cancer. And this may sound odd, because this runs contrary to the prevailing cancer discourse, which is cut it out or get rid of it. But this is not necessarily helpful, and it's not necessarily always true. Now, when it comes to treating localized prostate cancer, there are several options of treatment, and these are broadly separated into radical with curative intent. That is to say, the intention is to cure the person of the cancer. And then there are ongoing monitoring options where, in certain circumstances, the patient can move to a curative option should they wish to, or should it become recommended. So these are the main currently available treatment options for attempting to cure localized prostate cancer. Now, there are others, but they're still not far beyond the experimental phase in going through clinical trials. So surgery, as you'd imagine, this removes the entire prostate. There's also forms of radiotherapy, which can be delivered externally, like an X-ray, as well as internally by inserting radioactive seeds into the prostate. Now, I suppose it's worthwhile, I haven't actually mentioned, the prostate is a gland for men. It's for male reproductive, the reproductive system. And what it does is it actually pushes the sperm into the semen. Without this, a man or person with prostate is unable to ejaculate semen and sperm together. So this is something that's very important for enacting male identity. It's a relatively small gland, but it's one that typically does get larger with age. And it's when that growth becomes out of control that it can become a problem and start presenting as symptomatic for patients. The other two options are ongoing monitoring, which do seem antithetical to the cancer discourse of getting rid of it. One of them is active surveillance. And active surveillance is exactly as it sounds. The progress of the cancer is surveyed through regular blood tests, as well as biopsies and MRIs as necessary. However, the patient for this option has the choice to move to a radical and curative option should they wish to, or should it be deemed necessary. Watchful waiting is a similar version of active surveillance, but is distinct because due to various medical reasons, the patients on watchful waiting cannot move to a curative intent. So this is more a management option for the prostate cancer. What's most important about this, and this paper is getting on a bit, but there's nothing out there to replace it, is there's currently no clear advantage in selecting one treatment over the other in terms of 10-year survivability. And that includes the active surveillance option, which is often described incorrectly as doing nothing. Now, when it comes to the impact of prostate cancer and its treatment, these are psychological and they are physiological and they're also social. So distress and anxiety is one of the most salient impacts from a diagnosis, and this has been measured as clinically relevant for patients who receive a prostate cancer diagnosis. When it comes to treatment, surgery has several side effect risks and side effect realities. There is always a risk of infection from surgery, and the surgery can and often does lead to incontinence and sexual dysfunction, as well as infertility and a reduced libido for the patient. Radiotherapy has similar impacts to surgery. It has various forms of incontinence, fatigue. However, it does come with potential to provide brittle bone issues for patients who go through radiotherapy, as well as sexual dysfunction, infertility, and the impacted reduced libido. Active surveillance, on the other hand, has the fewest physiological impacts because there is no invasive treatment being carried out outside of the blood tests, MRIs, and potentially biopsies, which happen much less often. Nevertheless, the idea of having a cancer, so to speak, can be seen as having a ticking time bomb, which is how it's often described. And this has been described also as Damocles syndrome, which is basically having this cancer hanging over your head, waiting to strike at any moment. So this can cause fear as well as anxiety over potential progression. Now, I did mention the impact for couples, because the impact of prostate cancer is not just limited to the patient. When it comes to prostate cancer and older couples in particular, the one thing I do want to make clear is that sex is important for older couples. There is an ongoing sort of assumption that after a certain age, people just simply stop having sex. And this is entirely untrue, which is why this research is so important. I've got some quotes here that I want to show you, and I'll come back to later. Couples in this paper were revealed to grieve the loss of their sex lives. And this quote says, "We grieved for the loss of what had been." And this was after treatment for prostate cancer. And when it comes to enacting their sexual identities, couples realized that their sexual identity was actually integral to their marriage, and they simply didn't realize until it was gone. And patients reported reluctance to touch their partners. That is to say, they felt like they didn't want to give the wrong impression. And the quote here is, "I didn't want to start something I can't finish." And this was also upsetting for partners who felt like they were being isolated from the relationship and put to one side. And this quote from a partner, which was, "I simply can't turn him on anymore." And this is why Bullen and Todd recently, a little bit longer than recently now, described prostate cancer as one of several GU cancers that could be classified as couples cancers because of the shared impact of the experience and treatment for couples. So what I want to do now is give you an overview of the completed studies before I move on to talking about the research into the sexual impact of prostate cancer, as well as discussing a research project which is under development that was at the front slide, which is Sex and the Clinic, where there will be hopefully a project being put forward into how sex is talked about across multiple oncology settings as well as multiple clinical settings. So the objectives of my research, which were lifted directly from my PhD thesis, was to understand the involvement of partners during these consultations for localized prostate cancer. The first aim was to deliver a participatory framework for these consultations, which was the most time-consuming part of the entire project, to understand who says what, when they say it, in particular how partners obtain a turn at talk, and what they do with that turn and how it impacts the unfolding interaction. So looking at how and when partners contribute, as well as what they actually do, so the actions that they implement when they take a turn. And the reason why this has been focused upon is because previous work has considered the contribution of partners to inhibit the patient's ability to contribute themselves. And this relates to the idea of patient autonomy being an individual aspect of the patient. It should be isolated from all outside influence. So this research paper said that when partners speak for the patient, it inhibits patient's autonomy. However, as conversation analysts, we know that there is a specific amount of order in turn-taking practices. And this was something which I had on my mind when I looked at when I carried out the first study for my thesis. And that was a first and second order preference regarding turn-taking. So as Stivers and Robinson note, there is a first order preference for the selected next speaker to respond to a question. However, Stivers and Robinson go beyond this and note that there's a second order preference, which is if the selected next speaker passes on their turn, then the floor opens to someone else being able to take this turn without negative sanction. So this was the focus for my first analysis. Now, the paper itself is available in Patient Education and Counselling. And I'll offer a little bit of background on this because there's almost nothing until now on how partners come to contribute to the consultation through observation, or to highlight the communicative practices that they actually implement within the consultation. So previous work, as I'd noted, had suggested that partner contributions are akin to lay concepts such as interrupting or taking away their autonomy. And autonomy in previous work, as I noted, has been based on this individualistic concept of autonomy, where someone's autonomy relates to their individual thoughts, with decisions being made outside of the influence of external influences. So the initial finding for this paper was rather unremarkable, and that was that partners were almost never selected as the next speaker, despite the fact that research has highlighted an overarching preference by patients for partners to be involved and by partners themselves to be involved. But what this does mean is that partners overwhelmingly obtained a turn at talk through self-selection. And one specific practice that I focused on was when they self-selected to speak after the patient was selected as the next speaker. Often in English, this is described as speaking out of turn. So when it comes to this practice that I've called speaking out of turn using the lay term, the most important thing was that when this actually happened, contrary to research findings, it did not inhibit autonomy. In fact, it was autonomy enhancing. And what it did was it was actually patient enabling. So in these sequences, when patients had hearably passed upon their turn to respond as the selected next speaker, the partner coming in to talk actually served as a platform for the patient to elaborate and collaborate in a manner that was not previously forthcoming. And this was not in any way subject to any kind of negative sanction. In fact, it was continuously pro-social and patient enabling. And what was important about this was that when the partner came in to talk for the patient, the turn-taking sequence was responsive to the patient's primary right to respond nearly every single time. As such, this actually created space for the patient as an opportunity like a jumping off platform to elaborate and collaborate with the partner, which they did regularly. And the implications for this paper are quite clear for the enactment of patient autonomy when it comes to speaking to couples in the consultation. Now, I've got a couple of basic examples about this, and I don't want to stay too long on this paper. So this example is between a healthcare professional, partner, and patient. Now, one of the things I forgot to say at the beginning is I'm unable to play back the data. So I will attempt to perform this as good as possible, but it will be based on my own memory of the consultation. So the first line I will not attempt to perform because it had too many hitches and restarts. Have you seen the surgeons today? Are they, would they say they can spare a nerve or anything like that? So what's important about that is this is by sequential organization and the content and the context, of that question, a question that is designed specifically to the patient. That is to say, they're asking the patient if the surgeons can spare a nerve within their prostate. Now, nerve sparing is something that minimizes or seeks to minimize the impact of sexual function. What's important here is this gap here, which in conversational terms is a chasm. 2.3 seconds, as anyone who's studied social interactions will know, is a large pause. But then the partner comes in, and the partner says, we've only had one meeting with Mr. Then the name has been removed for privacy and confidentiality. So and at this point, the patient comes in not quite in overlap, but there's not much of a gap either. Well, he told us the results, and the partner elaborates with this as well, with just the results, clarifying that they told us just the results. So they're almost talking in chorus here. After this, the healthcare professional acknowledges, okay, just the results. So in this simple example, we see that when responding to a question that was addressed to the patient, the conversation unflows very naturally with minimal gaps and minimal overlaps in the interaction. In this example, the gap projects that the patient has also passed on their turn. So I will perform this one as well. And what's your imagination of how many people would still be leaking at 1 year? And for some context, this relates to urinary incontinence. As you see, the gap of 1.1 seconds, while it's not quite as large as the previous one, will still be hearable. The patient attempts to respond at this point with an elongated which is very creaky and difficult to hear. This can be projecting or can be hearable as a trouble source, to which the partner latches on, which you can see by the equal sign. So there's no gap and a slight overlap with no idea. Now, sequentially, the clinician has been talking about the amount of patients that will have incontinence after 3 months, 6 months, and 1 year as part of the longer conversation. And with each one, the number of patients that the clinician informed the patient would still be leaking has been reducing for each example of 3 months, 6 months, then 1 year. So with this in mind, the patient then latches onto the partner's turn with, no, I wouldn't have thought any. So this is another turn that was not previously forthcoming, to which the healthcare professional responds, so it's low, 1 in 10 wearing a pad, and a fewer, I think it said, a handful requiring surgery, which was 2 or 3%. So these just give you the idea of the participatory framework, which was the main purpose of that paper. And like I said, the findings were relatively remarkable, but the most important finding was when partners speak for patients, it enhances and does not diminish the autonomy. Now, the next paper was in Social Science and Medicine, and it related to decision-making during these consultations, and specific how couples express preferences in these consultations, and more importantly, how clinicians orient to them. And the paper is subtitled Implications for Clinician Misalignment with Couples Preferences. So that should give you an idea as to what we'll be analysing in these excerpts. When it comes to the misalignment with expressed preferences, it's important to understand that in these consultations, couples regularly express preferences for or against treatment choices. And they did so in fairly unambiguous terms, like, I don't want this, this is the one I want, this is the one I did not want. And they also expressed preferences for expert recommendations, which shouldn't come as a surprise because this is in line with a typical medical encounter where the doctor is seen to be the expert and the patient is seen to not have the same amount of knowledge. Nevertheless, shared decision-making is something that is expected within these consultations, and for the clinician to be sensitive to the expressed preferences. Nevertheless, while clinicians worked to enact shared decision-making throughout these consultations, they were seen to disalign regularly from expressions of preferences. And this included preferences for or against an option, as well as expressions for an expert recommendation that were dismissed rather robustly. Clinicians regularly moved talk away from these expressions, as well as challenging patient and partner understandings. The most crucial part of these exchanges was what happened after these misalignments unfolded. And what it was that both the patient and the partner silenced themselves. And this was evident in the lack of responses where a response was warranted. And this offers some kind of evidence of conflict management or avoidance, which is not great within this context. However, one clinician did things differently and offered an interesting deviant case analysis. So I'm just looking at an example of misalignment now. And for this, I'll perform once more. So, says the healthcare professional in line 1. The partner comes in, as you can see, self-selecting to talk. As far as I'm concerned, the sexual side, the cancer is the main thing. Now, what's important with this is that the patient collaborates with the partner with their response, which latches on with it is. The healthcare professional, however, comes in overlap with the patient's turn with, yeah, but in terms of, and the terms of is substantially louder than the rest of the talk. And the partner offers some kind of elaboration which we don't get to hear finished because the healthcare professional comes in again. So the partner says from the other side of and they get essentially cut off. And the healthcare professional reinitiates their turn with, but in terms of, then they pause just for a little bit before bringing their volume down. The package of 2 treatments, 0.6 second gap, 1.3 second gap, 0.7 seconds. These are all substantial. It depends on whether one seems to be more attractive to you than another. And what's important here are 2 things that need to be highlighted. First is the gap. This was a space where an acknowledgement was warranted. And furthermore, this was an audible outbreath from the partner. It was almost like an exasperated sigh. But specifically, this shows that from the other side that had more before that turn was finished. And essentially, the partner had more to say, and it expelled the air that they had taken in to complete that turn. In this example, I'm sorry, the text is a little bit smaller than I realized it would be. I hope that's visible okay. The healthcare professional is outlining what he has discussed during one of their meetings. So we've discussed it in one of our meetings, and everyone's agreed really that the best option for you would be something we call active surveillance. Now, what's crucial about this is that the patient latches onto this turn in slight overlap. Now, when they talk, their talk is interlaced with laughter particles as well as laughter within the clear. So they say, oh no, haha, no, I can't, that's the one I didn't want. It's very clear expression against active surveillance, which probably relates to the prevailing cancer discourse. What's crucial here is that the healthcare professional has initiated a turn in the middle of the patient's turn with so. Now, so has been analysed in many ways as the beginning of a turn which is progressing an agenda already underway. So this conveys the idea that the healthcare professional is about to continue on to the next phase of their information delivery. And what's important here are a few things after this happens, because the misalignment takes place on line 7. The word no is performed exactly like that, and the action that implements is effectively dismissing what the patient has expressed as a very clear preference. So, active surveillance is like PSA surveillance, which is what you've basically been on for the last year or two. So we have a gap of 0.3 seconds, followed by a lip smack, then okay, which pursues a specific response, another 0.3 seconds, followed by a further pursuit of because we have been watching your PSA, haven't we? Only at the third time of asking does the patient finally respond with what could only be described as a non-affiliative And this is not convincing at all. Now, for the deviant case, the one thing I do want to highlight is I've had to cut out a lot of lines because the patient and the partner carry out what could be described as a very long co-produced narrative between lines 7 and 29. So when you look at this, the healthcare professional starts with, right, okay, fine. So what do you understand about your prostate cancer and the options for treatment? Now, instead of there being any gaps, the next turn takes place in overlap. I listened to the man that I saw, the lady's colleagues, on Monday. That's the clinician that says that. And like I said, several lines from 7 to 29, where the patient and the partner collaborate in a long narrative, which then leads to the expression of preference. My way of life, which would suit me the best, and it seemed to be that radiology was the best. The clinician says, yeah, in overlap with the patient finishing their turn for me. What's crucial here is there are no gaps, there are no pauses or lapses, and instead the healthcare professional latches onto that turn with, right, yeah, good, okay. And the healthcare professional treats this preference expression as unproblematic and moves on to the next phase of the consultation. Now, for full disclosure, unlike the other consultations, this healthcare professional has only been talking about one treatment option to the patient. Nevertheless, we see a practice where an expression was made and it was treated as unproblematic, and the healthcare professional moved on to the next phase of the consultation. Now, why this matters is for several reasons. First of all, there's an expectation in these consultations for clinicians to be sensitive to the preferences of the patient. And this is part of institutional policy that preferences will be acknowledged and accepted where possible. What this paper shows is that the normal practice is where the clinician acts as an informant, delivering largely unilateral pieces of information for the patient without acknowledging or accepting the expressed preferences. And this is working to enact shared decision-making by ensuring that the patient has all the available information to make this informed choice. The exceptional practice, however, shows that the clinician instead acts to be informed. They solicit an extended narrative rather than closed sequences of questions and short-form answers. And the analysis offers practices that can foster shared decision-making through the exception to the rule, which was one clinician who acted differently in their consultations. And this shows that there are practices that enable exploration and there are practices which inhibit the exploration of preferences. So as I said before, my research that's underway relates to communicating the sexual impact of prostate cancer. And the reason why prostate cancer is described as one of several couples cancers is because of its impact upon relationships, and in particular, sexual relationships. Now, in order to enact fully informed shared decision-making, this means that the patient, and by extension the couple, need to understand all of the impacts of the condition and its treatment. And this includes the impact on sexual function and sexual relations as a relational and social activity. And just as a reminder, prostate cancer is typically diagnosed in older adults, but is occasionally diagnosed in adults under 50. And what I'm going to show you will hopefully highlight the differences between how clinicians communicate the sexual impact of prostate cancer depending on the type of couple they have in front of them. So first of all, just as a reminder, sex is important to couples. You saw the quotes previously, so I don't necessarily need to repeat them. However, there was "we grieved for the loss of what had been." An additional quote that I included here was a couple regretting not raising the topic in a consultation, saying, "I wish I'd told them." As I'd mentioned previously, men reported withdrawing from their partner, saying, "I don't want to start something I can't finish." And women reported a loss of self-esteem, noting that they can't turn him on anymore. And these are illustrative quotes from several research papers about the sexual impact of cancer. So this is the current paper which is in preparation. And what I wanted to do was understand how the sexual impact of localized prostate cancer is communicated to couples. So I wanted to examine the sequences where the sexual impact was raised for the first time and communicated, and how couples oriented to this communication. Specifically, what I wanted to look at was the actions that were implemented through particular practices within these sequences. What I found was that clinicians tended to make particular assumptions regarding sex and the age of the couples. Specifically, younger couples were assumed to be sexually active and that they wanted children. And in this respect, for old couples, they were always checked by the clinician to find out if they were still sexually active, using a commonly used clinical question, "Are you sexually active?" This was not asked of younger couples, and this is important, as I'm hopefully going to illustrate for you. So the sexual impact regardless, however, was consistently described in vague, euphemistic terms, with "are you sexually active" or without. So this long excerpt goes over 2 slides. So first I want to highlight the organization of the question with 2 contrasting examples. So the clinician says the other downside are changes to your sexual function. There's a half a second gap, which is relatively lengthy, to which the clinician then initiates the clinical question. Are you sexually active at the moment? There's a gap of 0.6 seconds, after which the patient comes in with, we are, but. Now this speaks to a form of organization which I'm hoping that I'll be able to convince you of as I show you some other examples. So what we have here is a question, we have a delay, we have a preface, we have an account, which speaks to the normative organization of this question. From there, the patient and the partner engage in a long narrative, which in short highlights that they want to underline that they've had a good run in their sex life and they want to prioritize curing this cancer over the maintenance of their sex life. So here's the gap. And this is the incoming response with a preface, a response, and an account. There's also a shaky voice throughout the explanatory account, where the partner comes in and supports the patient throughout this account. The excerpt continues with the explanatory account being co-produced by the patient and the partner. On line 27, the clinician comes in after the story is complete, where they say we've been very fortunate, which implies that they are prioritizing the cure over their sex life. But the turn on line 27 offers nothing about the sexual impact that is specifically useful. If you're I think that with surgery, certainly immediately things, if you're comparing with radiotherapy, surgery, the effect on your continence function is more marked with surgery. Then things tend to stabilize. And this is all that they get. They get continence and sexual function without specifying what that means to them as a couple. In this example, the gap in the interaction is followed by what could be described as a humorous tension management type response. So what we see is the question being initiated on turn 11. Are you sexually active? Now, what's important about this performance, similar to the previous one, is the reduced volume compared to the rest of the consultation and how it's performed in whispered, hushed tones. This results in a 1 second gap in the interaction, which is quite substantial, after which the partner and the patient, in almost direct overlap, offer 2 humorous type responses to this question. The partner says he's supposed to be, and the patient at the same time says, I bloody well hope so. Nevertheless, although they share some laughter, or at least the patient and the partner do, the clinician follows up with more vague terms of, so, of course, that can be affected by any of the treatments for prostate cancer. So we have more vague terms and nothing that's actually helpful or useful for the patient. Now, this is the one that I wanted to show you that's really important, because we've seen the organization of when couples respond. Yes, we see the performed with hitches and reinitiations. We see it performed in hushed tones in a manner that's doing taboo. We then see typically a delay, a preface, and an account, or some kind of humorous summing up to respond to the question. So what happens when the patient says no? And it's quite stark. So the healthcare professional has, just like the previous ones, been outlining some of the treatment choices and the impact of the treatments. Without any kind of introduction, the healthcare professional says, are you sexually active? It's performed again in the same way, in whispered, hushed tones with the elongated F. Crucially, here's what happens. We have no gap. In fact, we have a slight overlap. And the patient says, no. It's quite clear, it's quite direct, there's no preface, there's no delay, and there is no account. The difference is that there's a delay after the no. So just after that, it's the clinician that offers the account for asking the "are you sexually active" question by saying, we just have to mention that on the form as well, and can affect that side of things. So what we see here is that the sexual impact is described as that side of things. And we have some laughter particles throughout the healthcare professional's turn, which can be seen as easing some form of tension as well. Now, as I said, the research has highlighted some of the differences between older couples and younger couples. However, very few younger couples actually get diagnosed with prostate cancer. Nevertheless, I've just turned that off, sorry about that. What we have here is a protracted sequence for younger couples. And the healthcare professional says, and whereas I'd had another chap, a young chap like yourself, who went, I just want it finished, I want the worry gone, I want the tried and tested treatments, so you've got help. So this is important for the rest of the sequence, specifically because of a few membership categories that the clinician has drawn upon. And specifically what we'll find out is that these are being brought into the conversation to position and give the patient the stance of being the exception to the rule. Specifically a young chap, or in this case, a young couple as the exception to older couples. So as this sequence continues, there are a few ways that it becomes more explicit. In this sequence, the clinician continues with a lot of category work here. It's probably slightly harder when you're younger in a way. So specifically by contrast to older patients. And this is important because at this point, the patient recognizes what's coming. When the healthcare professional has been effectively beating around the bush about what he's trying to get to, which is fertility. The patient responds with their own information delivery that was not solicited, with children aren't a worry. I mean, I don't mind that I'm going to be sterile. Now, as this unfolds, the healthcare professional takes a turn in complete overlap across lines 51 and 52, saying, yeah, I was going to ask you then. And the patient has elaborated and expressed a specific preference, and they don't mind being sterile. Beyond that, they specifically say, but obviously, I want to, if possible, still carry on having a sex life, you know? And this offers these preferences explicitly to the clinician to acknowledge. So, not concerned about children, don't mind being sterile, but I do want to have an active sex life. These are key pieces of information that the clinician should acknowledge at least, if not also accept. And this excerpt follows just a few lines later. Now keep in mind that the couple have stated their position rather clearly at this point. Now I've highlighted just a few sections of this excerpt. So the healthcare professional returns to the children's side of it. saying that they can sperm bank where there's a half a second gap if you really wanted to. Now, what's important here is that the patient says, nah. Now, that's specifically dismissing this option, just like the clinician in the previous consultation who said, no. So have a think, says the healthcare professional, in near overlap with this response. So if you look at the equal symbols, from 1 to 2, nah, and so have a think, unfold with zero gaps in between those turns. So it's like the healthcare professional has just said, if you really, so have a think. It's that fast. And you don't have to say today. At this point, the patient responds one more time with no. It's quite clear and is unambiguous as their preference. The patient then elaborates further with, I can't see when, to which the partner comes in for the first time in this sequence with, well, no, where I'd want something no. So we have a lot of no's here. And crucially, although I've not shown these excerpts, the clinician pursues this agenda in 3 further sequences. So they pursue sperm banking 3 more times within this excerpt, including one where they make this humorous summation about you have to do it before the treatment and not after, while laughing about it. So what you see here between the young couples and the older couples is a contrast regarding the normative organization of talking about sex in the clinic, in that these convey the impression that the assumption is older couples have to be checked whether they're sexually active, and younger couples will be sexually active and they will always want children. So this matters for a few reasons. First of all, the sequential organization of these consultations limits opportunity spaces for couples to contribute to the consultation. So when you look at the deviant case of the expression of preferences paper, there are particular practices that, in fact, foster contributions. And this practice, despite the fact it includes an elicitor for the patient, does not offer opportunity spaces. The sexual impact itself, when it comes to content, was consistently described in vague, euphemistic terms and was delivered to the patient without any kind of orientation towards sex as a relational activity between the two of them. There was also an exclusive biomedical focus on sex as an activity and no focus on sex as relational or emotional, with connections between the couples or alternative practices that they can engage in to remain close to one another. And what we see here between the young couples and the old couples are ageist assumptions being enacted in the sequential organization of these consultations. But regardless of the approach, the talk around the sexual impact was largely unilateral. So when it comes to what's next, there are a few future research directions. More research is always needed, but in particular for this area, because the overarching problem is the sexual impact of prostate cancer has been reported as an unmet need, and this is over multiple oncology domains. The reasons have been explored in research using interviews and surveys. And clinicians report that they are reluctant to discuss sex with their patients, drawing on the concept of sexual taboos in society and ageist assumptions with their patients. And they assume that older couples don't have sex. And older patients themselves also orient to this taboo and assumption because they are worried what clinicians will think of them if they raise the concerns with the clinician. And that's the paper where there is the quote, "I wish I'd told them," because it leads to serious regret. Nevertheless, this is consistent across multiple clinical settings: primary care, sexual health, oncology, but also MSK, diabetes, endometriosis, HIV, and others. The research to date, however, is limited in a number of ways. It's currently limited to work in the UK and in Europe. And more importantly, there's very little work that has carried out direct observation-based studies. So there are interviews, there are surveys, and there are 3 single ethnographies in in Africa and New Zealand. There is a single observation study in South America, which is a fantastic piece of work on contraceptive decision-making. So as a starting point, what I'm hoping to be able to do in the very near future is understand how sex is discussed and communicated in oncology consultations, starting with a paper that is in preparation for submission. I'm hoping to explore understandings and experiences of talking about sex in clinical consultations in areas that up until this point have been overlooked, such as UK and Europe. For this part of the project, I will actually, somewhat counterintuitively, be looking to solicit information from key stakeholders through interviews, and by using a qualitative mixed methods approach, also examine how sex is discussed and communicated during these consultations, which you will not be surprised to learn will be by using an analysis of recorded consultations that will include ethnomethodology and conversation analysis. And the hope is to improve the delivery of service in this particular area to lead to improved shared decision-making and fewer decision regrets and an improvement of service delivery across these clinical contexts.